So you mentioned kind of the burgeoning field of partners from a radioligand standpoint, and we'll get back to that a little bit. But in terms of other new therapy combinations coming, I'd like to kind of touch from each of you kind of the things you may be most excited about. But you brought up a great point earlier, which is a lot of the trials are taking treatment-naive patients who've just been on ADT and are progressing now in their CRPC, but they've never been exposed to anything. And now we're having combination therapies that have been approved with a very different patient population than we hope that we're seeing in clinic, because that means they've been undertreated in the hormone-sensitive space. So kind of just if you could touch on that disconnect between what the trials show us and where we are when they get released 5 years later, but also what are your other options for therapy lines, mechanisms of action that you're interested in, whether it be PARPs, whether it be something else that's potentially coming down the road. Dr. McDuffie?
Well, I think you hit nail on the head with the first one, that I'm excited about PARP inhibitors, being able to use the NGS and seeing those BRCA mutations. I've got a couple on therapy now that are doing quite well, and also seeing some of the studies where they're used in combination with other drugs. I'm also excited to see what becomes of not specific drugs, but how we use NGS like AR variants and whatnot to kind of help guide therapy. I'll defer to the more professorial part of the panel, the specific active compounds that they're excited for, but definitely excited to see how NGS helps us make decisions and sequence these therapies that we got, a lot of which are now kind of getting into Me Too space, if you will.
So I want to stick with that for a second. So you mentioned NGS,
Yes.
Testing platforms, tissue, blood, archival tissue, new biopsies. What's kind of your preference and workflow in the community? Because that's often very different than in an academic setting.
Tissue, and more tissue is
Okay.
always our preference.
Okay.
But the problem is, a lot of times you're seeing somebody at this point who was originally, local disease, received radiation, received surgery, what have you, and is now, metastatic to bone, which is not, the highest of yield tissue, sometimes difficult to get. We will certainly use liquid-based assays if we can, but certainly the preference is going to be tissue-based NGS.
And are you repeating that? Say somebody had seen you up front, hormone-sensitive disease 2 or 3 years ago, and you had testing which was negative at the time for the mutations that kind of got mentioned, so you treated them.
Correct.
And now they progressed. Are you re-challenging them? Are you treating them to see if they've had some sort of shift in their tumor before you move to the next line of therapy?
Typically, yes, unless it's somebody who I've gotten an NGS on and started them on a therapy that they were just kind of primary refractory to. So I've had a relatively quick NGS or recent NGS, I won't. But if it's a patient who has done well, reasonably well for some time, and now they're having a change in clinical status, they're no longer castrate sensitive, or they're having progressive disease, certainly we'll look at repeating NGS, and just depending on how difficult it is to get tissue.
Okay. Go that way. Before we guys get your mechanism of action, a similar sort of testing paradigm in an academic setting? I mean,
yeah, I think so. I mean, we might vary amongst ourselves too, but we're in the area of precision medicine. It's good to know more information, right? So I like to do upfront dual liquid and tissue. I think it captures the heterogeneity, and when cancer progresses and becomes castrate resistant,